Do we have more reasons to use ketamine over fentanyl? Let's talk about it today on MAJC. Hey everybody, Ed Bowder and Dan Schwester from the Overrun here, Monday afternoon Journal Club. How we doing, Danny?
We're doing great, Ed. How are you?
Doing good. Still coming off that high of the conference a couple weeks ago, but let's go ahead and talk about this paper we found today. This is coming out of the Annals of Emergency Medicine. This is talking about giving ketamine in addition to fentanyl for pain management. What they looked at here was we gave out-of-hospital intranasal ketamine as an adjunct to fentanyl in acute traumatic pain. How they did this study was any patients who were qualified for pain management would receive fentanyl, and then they randomized patients into a ketamine and a placebo group. Really, really well done study. The N is a little bit small, 192 participants. One big factor on this were all the patients involved in this study were white men. So that's just a big asterisk, big caveat to put out before we get into this. It is a little bit weird. I can almost understand for this data set if you're just looking to see like the majority of patients that you might see. And also importantly, this paper is coming out of Ohio. So out of Ohio here, again, in this sample, we did not detect an analgesic benefit of adding 50 milligrams intranasal ketamine to fentanyl in an out-of-hospital trauma patient. Now, again, something we mentioned about Annals, one of the things we like is this editor's capsule summary.
Yeah, love it.
So it's one of the best ones. You know, you never want to read an abstract, just the abstract, because it doesn't really give you all the information you want. One of the things that Annals does really well is they kind of, encapsulate this whole study in this capsule. So here, we know ketamine offers analgesia and can be administered intranasally. They wanted to look at, does it improve analgesia over time? And then how is it relevant? The added benefit of EMS-administered ketamine after fentanyl for analgesia in those with trauma is small, if existent. So we go through all this. There's one graph that I want to show because it actually shows how, so this is the selection criteria. And then this graph down here will show the effects of placebo against ketamine 30 minutes after fentanyl administration. So we see here placebo and ketamine essentially have the same range. The range that they were looking for was they asked the patients their pain scale after they were given this medication. So in this study, the way that it was done is a traumatic injury receives fentanyl, and then they would give either a placebo or ketamine on top of that treatment. Really not a bad study design. I like that they used a placebo. But what they found was that adding ketamine to fentanyl did not improve pain management. And that's kind of what this paper landed on. Not necessarily practice changing, really interesting data, but what did you think about this, Dan?
A couple of things that kind of interested me. First and foremost, people will say the study's a little underpowered, but hey, any EMS-focused research is good. We should be supporting this. We should be celebrating it. We should be doing it ourselves. But you've heard me say this tons of times. Secondly, I'm a little surprised at the results because if you think about, fentanyl, working on the opioid receptors, relieving pain, and ketamine being an NMDA block antagonist, you would think it's kind of hitting it from two different angles, so you might get a better result, which didn't happen in this case. What's the takeaway? I think the jury's out. I don't know if this changes practice because, again, it's an intranasal route. We don't know about the absorption, but it was a good study. What it shows me is mixing ketamine and fentanyl in this manner may not give you what you want to get your patient's pain control.
No, I think that's right. And I think another important fact to add to this is that the basis of this study was we're going to add ketamine to fentanyl. So I think we can kind of get away from the debate of whether adding fentanyl or ketamine to fentanyl is dangerous or not. Right. You can add these two drugs together and it's generally safe for the patient, which I think is an important thing to acknowledge just going into the study. One of the hangups here. So the first thing is there's an issue with all of the sample being white men. There's always that bias in medicine, right? Everything in medicine is based off of a 70 kilogram white male. So that's the first thing, right? So that not that causes problems. It's just that to me, that makes it an incomplete data set. And beyond that, and again, I don't have a solution to this. I don't know how you would design a model to get the results that I'm looking for, but
I don't think you can ethically do it because
exactly. Yeah.
You'd have to randomize control trial. Somebody would have to get placebo in a pain situation.
Right.
That's not cool.
And I don't know. And I'm not super supportive of that. But if the patient's already gotten fentanyl and we're giving intranasal ketamine and what they did was they analyzed the patient a half hour later. So these patients are already, and I hate to say under the influence of fentanyl, but they already have received fentanyl. They've already received analgesia. We know that patients are bad at estimating 10 scales anyway, right?
Sure.
Because asking a patient to rate a scale of 1 to 10 is a very vague thing. The story I've told my whole career, I had an abdominal surgery when I was a teenager and I woke up during it. So that was my 10, right? But as I'm presently in no pain, if I stub my toe, right now, my pain's going to be a 10 because I went from having no pain to only pain. So it's not easy to really scale that pain. And I think what makes it more complicated is if you've received analgesia and then we've gotten more and like, all right, well, your pain was at a 6. Where is it now? Like, that's a question that's always frustrated me in the back of the truck too. You know, like in a chest pain, you're giving nitroglycerin. Like, well, your pain was a 7. Would you say it's like a 6 or a 5 now? Like, I don't know how helpful that really is, whether someone's pain went from a 6 to a 4. And that was one of the criteria here. They used a 2-point scale on the change of pain. So, but given all of that, I'm not convinced that this means that ketamine doesn't work.
I don't disagree with it.
Yeah, and I'm not really sure how you could do a study that would say, you know, does fentanyl have an effect over ketamine unless you did a similar type of model here. But I do think that it shows that, all right, at least ketamine doesn't make patients worse.
No, it doesn't. And I think the interesting thing here is another point to make is that we're just talking about traumatic pain as opposed to other types of pain. You know, I think we need to look at burn patients, muscular. I would have liked to have seen it stratified into burns, musculoskeletal trauma, abdominal trauma, to see what had a better result. I'd also like to see somebody do something with physiological findings. Does my heart rate decrease? Does my blood pressure come more normal? Do we notice the end tidal goes up because the patient's breathing more effectively and they're not breathing 32 times a minute shallow because it hurts? These things would be more objective assessments. But this is a great start. I like this. I like where we're going with this. And I think we need to do more.
No, I think I agree. You know, moving to intranasal ketamine for trauma is not terribly new. I mean, I guess the data first started coming out about 2 or 3 years ago. So I think that that's a good move. I certainly think giving ketamine intranasally is going to be easier in the field, especially with some traumatic patients, just because, you know, if they have fractures or they have, you know, some sort of deranged physiology, which is very difficult to start an IV on. I think this is a good outlet. And I think it's a very good way to actually administer a medication that can be super helpful.
Military medicine would be looking at this. This is a great option for military medicine to be able, instead of a morphine syringe or a fentanyl or a lollipop, to give them a nose spray of ketamine, control that pain, and now they can be medevac.
Yeah, and it might be that, you know, this might be effective where you have patients who need to be moved, right? You've got someone on like a 3rd or 4th floor where you know that you're going to have to either stabilize them or maybe do an RSI procedure. It might be easier to give them intranasal ketamine, at least get that on board to start actually reducing that pain before you move the patient. So no real, you know, clear practice changing things out of this data set. But I think it's important that we understand that you can give ketamine and fentanyl simultaneously with no real untoward effect for the patient. And you can give ketamine safely along with giving fentanyl safely. So you want to know what you guys think? Check everything out that we do on Spotify, Apple Podcasts, and on YouTube. For the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester. We'll see you guys next week.